Thank you.
So we come to the last very, very important and very interesting case presentation, which is going to be moderated by Dr. Chandrika Bhatt and Dr. Narendra Bagri. The mentors are Dr. Angelo Ravelli and Dr. Ankur Jindal. Dr. Angelo Ravelli is the scientific director of the Giannina Gaslini Institute of Genoa, Italy, and professor of pediatrics at the University of Genoa, Italy. His field of clinical research activity focuses on pediatric rheumatology. He is currently the president of the Pediatric Rheumatology European Association, PRESS, and the past chair of the EULAR, Standing Committee for Pediatric Rheumatology. He has received numerous grants and awards, including the Gerolamo Gaslini Prize for Excellence in Research in 2004, and a grant from the American College of Rheumatology, ACR, and the European League Against Rheumatism, EULAR, to conduct the project aimed to develop the new classification criteria for macrophage activation syndrome in systemic juvenile idiopathic arthritis. Professor Ravelli was the chairman of the International Consensus Conference, which led to the development of the new classification criteria for macrophage activation syndrome in systemic juvenile idiopathic arthritis, and of the International Task Force that developed the recommendations for the treatment to target strategy in juvenile idiopathic arthritis. Professor Ravelli is author or co-author of more than 400 scientific papers and has been invited as speaker in more than 250 international congresses. On Google Scholar, he has more than 30,000 citations and an H index of 87. So welcome, Professor Angelo Ravelli.
Thank you very much.
The co-moderator for this program is Dr. Ankur Kumar Jindal, who is an MD Pediatrics and a DM Fellowship at the Pediatric Clinical Immunology and Rheumatology at the very prestigious Postgraduate Institute of Medical Education and Research, Chandigarh. He is head of the Angio-Edema Center of Reference and Excellence. He's the APSID Junior Members Working Party Country Representative from India 2020. He's a founder member and General Secretary of the Hereditary Angioedema Society. He's a founder member and Joint Secretary of the Indian Society of Kawasaki Disease. His primary areas of interest are hereditary angioedema, primary antibody deficiency, Kawasaki disease, scleroderma, and uveitis. Welcome, Dr. Ankur Jindal, to moderate this case presentation. So I hand it over to Dr. Chandrika to take over the case presentation.
Thank you, sir. So Dr. Narendra, if you could just ask your fellow to upload their presentation.
Yeah, good evening all, and thank you for this opportunity. And without wasting much time, I would just, we are going to present two interesting cases which has difficulty in management. So first I would invite Dr. Ashwani, who's a senior resident with us. Dr. Ashwani, please. Yeah.
Thank you for the introduction, sir. Is my slide visible?
Yes, it's visible. Yeah. Please go.
Okay, thank you. So I would start with a case presentation. It was a difficult to manage case. It was an 8-year-old boy who presented with a complaint of generalized swelling of the body, intermittent fever, and rash on the face for 1 month. He also had myalgia and proximal muscle weakness for 3 days. And there was a complaint of reduced urine output as well for 2 days. There was no complaint of any cough, cold, or other respiratory issues. There was no palpitation, no joint pain, alopecia, or oral ulcers, or photophobia, or any weight loss. There was no complaint of any jaundice, loose stools, or vomiting. So when he came to us, he brought a few investigations from outside. The blood counts were normal. And on biochemistry, there was elevation of AST and ALT. The AST was 1455 and ALT 692. On urine examination, there was proteinuria and few RBCs in hyperfit. So with the complaint of generalized edema and proteinuria, he was referred as a possible case of nephrotic syndrome. However, on examination, apart from the generalized edema, we could also notice some signs suggestive of juvenile dermatomyositis, like heliotrope rash, periorbital puffiness, malar rash, Gordon papules on the hands, and proximal muscle weakness. And his vitals were normal, And in abdominal examination, there was diffuse tenderness. However, there was no organomegaly or shifting dullness, and bowel sounds were heard normally. And other systemic examination were also normal. So with the clinical features suggestive of juvenile dermatomyositis and an investigation with proteinuria, we kept a possible diagnosis of juvenile dermatomyositis with the overlap disease, probably SLE. And we evaluated the patient further. And in the blood counts, we could notice that the hematocrit level was elevated with a PCV of 44.5 to 45.6. And the WBC counts were also significantly elevated. It was 23,880 and 49,370 on day 3, which was neutrophilic. And in the biochemistry, there was hyponatremia, hypoalbuminemia. And as part of evaluation for dermatomyositis, we did the muscle enzymes, which were significantly elevated. And an MRI thigh was also planned. However, as the child got sick, we could not get it done. And we did a urine routine microscopy examination, which this time, however, did not show any proteinuria or RBCs. And we did a myoglobin as well, which was negative. And in the inflammatory markers were slightly elevated. The ferritin was in the range of 1044, at triglyceride 742, and PCT 3.7. As we had kept the possibility of SLE as well, we did the ANA C3, C4, which were normal. And the bedside echo was done, which showed a collapsed IVC and with normal ventricular function. And an ultrasound abdomen was also done, which showed loaded bowel with minimal free fluid and gallbladder wall edema. And they also noticed echogenic iliopsoas muscle, probably suggestive of myositis. So with these, we revised our possibilities and we kept a diagnosis of juvenile dermatomyositis in view of characteristic skin lesions, proximal muscle weakness, and elevated muscle enzymes. Possibility of macrophage activation syndrome was also kept in view of increased ferritin and triglyceride. However, the child was afebrile since admission and there was no cytopenias, organomegaly, and other lab parameters were also normal when we evaluated further. And we kept a possibility of infection also. It was high on cards because there was increased TLC, WBC counts and procalcitonin as well. However, again, the child was afebrile and we had done blood culture and urine cultures, which were sterile. And also, since the child had edema and hemo concentration as well, we had evaluated for dengue as well, which was also negative. So, but the things troubling as well, an elevated TLC count along with evidence of hemo concentration, anasarca. So, which were not fitting into any of these parameters.
So, Dr. Ashwini, if you can just pause for a moment.
Dr. Ashwini, thank you for this presentation. As we rightly had seen that this child first deceived us as presentation as a nephrotic syndrome, and most of my colleagues who are practicing rheumatology would agree that at times there could be severe edema, particularly subcutaneous edema in JDM, which may manifest as clinically look like nephrotic syndrome, but actually they are not. And as in this very case, when we repeated the urine RM, it did not reveal any proteinuria. But what was troubling us was this high PCV and high counts and in setting for fluid overload. So I would like to have comments from the house to guide us about the possibilities of this inset, although we could reach a diagnosis of JDM. But what exactly was happening in setting of a GDM, though mass was also kept as a possibility, as rightly shared by Ashwini, that the child was afebrile and the other parameters were not meeting. But the troubling points were again the very high PCV and the high leukocyte count.
Can I make comment? Tell me if when I should make a comment on that.
Yeah,
if you wish.
Sure, sir.
Should I make a comment now?
Yeah.
Yes, please do, Dr. Ravelli.
Let me first say that there are no doubts that this patient had juvenile dermatomyositis, because the rash is quite typical. she had all, at least some of the most typical features of JDM, heliotrope rash and Gottron sign, but also malar rash is quite common in JDM. At least we see quite frequently, even though it is slightly different from the malar rash that is seen in lupus, because it's less well demarcated. It might involve the nasolabial folds. I don't remember. So this is the difference between the two. One involves the nasolabial folds and the other one not. So this is important. And also in JDM, the malar rash is clearly associated with the heliotrope rash. So it's what is frequently overlooked is that edema in JDM is more common than usually thought. It is usually limited to the face and to the orbital areas, but is considered a sign of severity, of aggressiveness of the disease. It can be also a poor prognostic sign. So the presence of edema might need to require a more aggressive therapeutic intervention to control the disease. And the patient also had a prominent muscle weakness. Of course, it can occur that in the presence of this edema, the disease can be misdiagnosed as nephrotic syndrome because of hypoalbuminemia, which is related to fluid retention overload. But on urine analysis, there was only trace of protein. So, of course, nephrotic syndrome is easily ruled out. So, and also another issue, other lab tests that are not consistent with lupus is the negativity of ANA. So there is no lupus that is ANA negative virtually. And also C3 and C4 were normal. Also, there was no myoglobin, which could have ruled out other form of muscle. So, you know, it is quite known that a fraction, a sizable proportion of children with JDM may have an acute onset, very acute onset with acute inflammation. Of course, there are many who have chronic or subtle or subclinical presentation, but it can be that JDM develops with a very acute onset. In this case was really exceptional in its severity because there was a really remarkable leukocytosis. There was probably capillary leak syndrome with diffuse edema, but still, I think all this, and also there were some evidence of triggering of mass because ferritin was 1,000, and also triglyceride count was extremely high. There was no fever, I understand, but you should consider that MAS may be slightly different across diverse rheumatic diseases. So we have seen MAS in some cases of JDM. It is often not considered as it occurs with Kawasaki sometimes because people do not think or do not believe that MAS may also complicate these conditions, and therefore corticosteroids are started immediately, which might control the disease and MAS together. So MAS is not diagnosed. But still, we have seen some children with JDM who had, like your patient, evidence of occurrence of coincidence occurrence of MAS. So in my view, what you should do in this case, as you did, is to on one side to treat aggressively JDM, because it is clear that if you control the underlying inflammatory process, you might also control the capillary leak syndrome. And on the other side, of course, you should treat this condition with appropriate therapeutic interventions.
Yeah, thank you for your valuable comments, sir. And I do agree with the fact that, yeah, sorry.
Yeah, please, Dr. Narendra, please go ahead.
Yeah, I was just re-emphasizing the fact that what Dr. Angelo surfaced, that at times the GDM may be tricky, and particularly the edema part is often overlooked. and it may be deceptive at times to make the clear diagnosis of GDM. So having made the diagnosis of GDM, the challenge again, as Dr. Angelo has highlighted, was the kind of presentation, the extreme presentation of weakness, as well as the leukocytosis and the raised PCV, which probably was suggesting of a capillary leak which was happening around, which was suggesting that probably the child, and subsequently, as Ashwini will shortly share subsequent course, can we proceed further so that we learn how the patient moved further, and then probably we can take the discussion. Is it fine? You want to make some comment, Dr. Ankur, now?
Okay, I agree with Dr. Ravelli on all the points. I just thought I'll make some additional comments in addition to what Dr. Ravelli mentioned. So nephrotic syndrome like presentation I think as rheumatologists, all of us must have encountered. And I'm just wondering if this patient was given steroids before this patient was referred to us, because most of the patients that we have seen who presented as nephrotic syndrome were actually treated as nephrotic syndrome, and all of them received steroids. So I'm just wondering, because that can explain 2-3 points in this child. This patient had a little bit of hypertension. At the age of 8, she has a systolic blood pressure of 124. Yeah. So a little bit on the higher side. So that probably can be explained by use of steroids. The leukocytosis this patient is having, so that is something which can be explained by users of steroids. And she's not mounting any fever spikes. So again, so we need to look if she has received steroids. So this is more of an acute presentation, which you sometimes see in patients with JDM. And the edema is a common presentation presenting as nephrotic syndrome. So it's a form of vasculopathy going on in these patients. So that kind of leads to edema. So these patients sometimes present with GI vasculopathy, which is again an acute presentation. Mass may still be a possibility in this child, but considering the fact that she's having high TLC, procalcitonin being high, I would consider infection as a possibility. Even you don't have an evidence of infection in this child, the cultures are sterile, I would still consider covering for infections in this particular condition, in addition to use of immunosuppression for JDM. So I think that is what my take is on this particular case.
Fine, I think perfectly, and they're very relevant point that you have brought, and this is what exactly was happening when we are managing the case. Ashwini, can you just please proceed further?
Yes, sir.
And unfold what exactly happened. Yeah.
Should I second the slide? It's not moving.
It's visible.
Just click on the slide once and then move it.
Okay.
It doesn't proceed.
Yeah.
Okay.
Yeah.
Right. It's gone.
Yeah.
So after admission, this is the further course of the patient. By day 2, the patient gradually started developing features of shock, and he also developed oliguric AKI, and there was worsening of edema and hemoconcentration as well. So keeping a possibility of infection also, we started the patient on antibiotic, piptas and teicoplanin, and infective workups were done. And fluid management was done for the patient, which was a little tricky because as patient was in a fluid depleted state with a collapsed IVC and hemoconcentration and a generalized NSRK and capillary leak as well at the same time. So we had to start the patient on inotropes as well. And on further evaluation, as we can see, the hematocrit kept on increasing, and the WBC counts also increased up to 56,000, which was also neutrophilic. And there was hypoalbuminemia, hyponatremia. For 115 sodium, we had to give 3% saline also for some time. And the repeat ferritin also increased to 6,000, and the other inflammatory markers also increased. So,
if we can just pause here, Dr. Ashwini, and I have a question for Dr. Ravelli here. So would you consider doing a bone marrow at this point in time?
This is an interesting question. It's difficult to say. It's not really fundamental in my view, because the only reason could be the extremely high white blood cell count. But unless you suspect that an infectious complication such as leishmania, I don't think it's it could be fundamental. But my question, just a question, was the patient already on steroids at this time?
Yeah, so the patient was not on any steroids. Am I right, Ashwani? I think he has not received any steroids from outside when he came to us.
Okay,
No,
so
sir, we did not receive any.
you know, we know that in adults JDM not JDM, sorry, dermatomyositis may occur as a paraneoplastic syndrome, but in children is extremely rare, exceedingly rare. So with such a typical cutaneous skin picture, with such typical skin manifestation, with profound muscle weakness, with such elevated level of muscle enzymes, I won't really consider a leukemia. So if you would like to be extremely prudent, perhaps a bone marrow you can do, but I won't perform the bone marrow aspirate to confirm MAS, because you know, you have ferritin 6000, so and other triglycerides were extremely high, but it's quite unexpected. They decreased to 231. So in general, what I can say, there are 3 points that I want to make. First of all, there are some complications of MAS or cytokine storm syndrome, whichever way you want to call them, that are overlooked. One is certainly microangiopathic anemia, which is not the case because hemoglobin it was very good and platelet count was also in some way satisfactory. And the second is capillary leak syndrome, which is another complication where there is a very high level of inflammation. It might occur because of cytokine derangement that is related to this condition. And so, and the third point that I wanted to make is that I had experience, not directly because I was consulted for that patient, that in a child with MAS, it was an isolated MAS with severe capillary leak syndrome, the administration of intravenous methylprednisolone at high dose had a kind of paradoxical effect. It worsened the capillary leak syndrome. Can't explain why, but just would like to give you this kind of anecdotal experience. So it's interesting. So it's at this point, of course, you have the priority is you should work on with therapy on two directions. First, to let's say to control the fluid unbalance, and then on the other hand to try to suppress the underlying disease, because of course this is fundamental to control the underlying disease at the same time as control the fluid balance.
Thank you. I think Dr. Ashwini, you can just carry on with the further course.
With this presentation, with the severe capillary leak, we kept a possibility of JDM with capillary leak syndrome, which was however, rarely seen in cases of juvenile dermatomyositis. And we searched the literature and we could find a case series published in Rheumatology Journal. And like our patient, these patients also had anasarca. They presented with typical features of juvenile dermatomyositis, and on evaluation, they were found to have elevated WBC counts, as we can see here, even up to 46,000, 22,000, 29,000. And they also had high hematocrit values, and there was hyponatremia and hypoalbuminemia as well. So many of these cases had worsening anasarca, and one of them even required fasciotomy to relieve the compartment syndrome secondary to it. And these cases were treated with IVIG, and all these cases eventually improved.
Yeah, thank you, Ashwani, for just once we landed up with the diagnosis of GD with capillary leak syndrome, this child. The further question was how to manage this child, and this was very tricky because, as Dr. Revelli had just pointed out, that we were dealing with complications like there was fluid leak at one point. There was at the same time the child was anuric. At the other hand, the child was in shock, so intensive. monitoring the fluid intake output and maintaining the fluid balance was a real challenge. And the second point that what Dr. Ankur has pointed out, that infection was again in our mind, particularly because the child ended up during this season of dengue, and we thought that are we dealing with a coexistent dengue, though it came out to be negative. So fluid management was a big challenge in this child. And then what immunosuppression, because again, because of that paradoxical reaction of methylprednisolone worsening this was again an apprehension. And in this case, though we started with maybe Ashwini, you can take on to the next slide and we can discuss what exactly was done. And then we can take the comments from the experts.
Yeah, right. So now, after admission, we started as mentioned, started the patient with antibiotics and IV fluids, and later inotropes had to be added. And so in view of possibility of capillary leak syndrome, we treated the patient with IVIG 2 gram per kg given over 2 days. And after that, there was a slight improvement in clinical status. The shock features of shock gradually improved. And the patient had a worsening NSRK initially. After around 4 or 5 days, that also started resolving slightly. And once we have ruled out a possibility of infections, we started the patient on methylprednisolone pulse therapy as well, given for over 3 days. And for AKI, which was believed to be pre-renal, the patient had to be started on hemodialysis. And following that, as we can see, there was a slight improvement in the clinical status. However, after around a week, the condition of the patient again started deteriorating. And there was probably evidence of sepsis, because even though the cultures were negative, we could find a consolidation on chest X-ray, and there was new onset fever as well. The patient started developing features of shock, again AKI, and even though the NSRK has reduced and the hemo concentration was coming down, then again there was pleural effusion. So we had to upgrade the antibiotics, which we upgraded to meropenem and teicoplanin and later colistin. And inotropes were started again, and the patient also started developing thrombocytopenia here, and keeping a possibility of fungal sepsis as well. Since we had given pulse steroid also, we started antifungals as well. So, however, the condition did not improve much, and the inflammatory markers also kept on increasing. So since there was evidence of sepsis as well, we we started the patient on plasma exchanges. We gave around 3 cycles of plasma exchange, and we had to restart hemodialysis also. But unfortunately, the condition kept on worsening. Now, later the patient developed pulmonary edema and a picture of ARDS as well. And we had to start the patient on mechanical ventilation and blood products for the thrombocytopenia and anemia. And the patient went on to develop DIC. And unfortunately, eventually the patient succumbed to illness, and in spite of all these measures.
Yeah, so it was very unfortunate that they will lost the patient. So in this regard, as we were discussing, that we offered the patient IVIG methylprednisolone, and given the fact that he has an concomitant infection during the hospital course, we resorted to plasma exchange as an rescue therapy in absence of other therapies. So I would like to take comments of Professor Revelli. What else could have been done?
Just a question. What is AKE? Just.
Oh, sorry. It's acute kidney injury. It's
okay.
Okay.
Sorry. Yeah. Sorry. What can I say? It's as I said in my before, edema is a poor prognostic sign, and capillary leak syndrome is much poorer prognostic sign. So patients with this complication are at high risk of a fatal outcome. If I understood well, this patient died.
Yeah.
Okay, I'm sorry for that. Anyway, what can I say? As Randy, my very good friend Randy, wrote, that child that I mentioned who had anasarca and capillary leak syndrome and paradoxical response to steroid went well with the combination of cyclosporin A and anakinra. But I know that anakinra is not available in India. If I think it is still the case. So what could have been done in this patient to prevent this? Of course, everything is hypothetical, of course, because the patient was extremely severe. He or she, it was a lady, ended up with a microangiopathic complication with DIC and the ARDS. So in general, these patients need to be treated extremely aggressive, not only with corticosteroid, but also with immune suppressants. And for JDM, the most effective, potentially effective immune suppressants are cyclophosphamide or nowadays, or rituximab. We have in our unit a very good experience with rituximab in children who are resistant to conventional therapies. Of course, in such desperate case, you need to try desperate therapy. And even I know that there was a high risk of infection, but still there was leukocytosis, so there was no major perhaps risk. Of course, the capillary leak syndrome involves a high risk of infection itself, but in such desperate case you need to be extremely aggressive. Because otherwise you run the risk of not controlling the underlying process. So you can even associate plasma exchange, rituximab, of course, by synchronizing the administrations, and even cyclophosphamide together. Because this case, I've taken a look of these reports in the literature before the entering the Zoom. But your case is much more severe than those reported in the literature. I mean, clinically, much more severe. So it's
yeah, we do agree that, and it was a severe case, and aggressive management is the key. But probably, though we started steroid, but we could not get a window of starting cyclophosphamide and rituximab, because at the same time he got hospital-acquired infection. And
I understand. I understand. You should balance the risk for infection with the risk of a grim course of the disease, which is, I understand. This is a typical case in which it's very difficult to balance the intervention and the decisions, the therapeutic decisions.
Thank you for your comments. Ashwini, can you just move on to the next slide? Yeah, so before we Ashwini, can you just take it further?
So I just have one comment to make, and actually a question to moderators, mentors. So with uncontrolled inflammation and this degree of capillary leak that this child had, these were probably risk factors for developing infection in itself. So achieving a balance with controlling the underlying inflammation with aggressive immunomodulation in the background of them already developing an infection because of the disease itself. So would you be aggressive at the outset, or would we wait to make sure there is no infection and then proceed? Dr. Ankur or Dr. Raveli?
Ankur, you want to start?
Okay, so I think this was a very challenging case. I agree, and in rheumatology we often see such cases like JDM or SLE, wherein when they present to us, we don't know whether it's more of a disease activity or more of an infection. So a very common situation, but you end up treating for both. And this has been the situation here as well. So, so in my opinion, the way I would have treated, in addition to what has already been done, and I think it has been managed very well. So I would have probably given a slightly more longer course of methylprednisolone to this child, although I'm not saying that this would have changed the course of the final outcome, but probably give more courses of methylprednisolone, considering the fact that we do not have better immune modulatory therapies like anakinra with us. So that is something which we have been doing and have felt that the outcome kind of improves with the slightly longer course of methylprednisolone. IVIG definitely we would have given. Hemodialysis for renal failure. Cyclophosphamide, yes, we would have given. Although cyclophosphamide, rituximab, they do take their time to produce its effect, but that is something we would have done after giving an adequate cover for antibiotics and antifungals. So that's my take on this case. But I agree, it's a very severe, very challenging case. Despite giving all these therapies, some of these children do not survive.
What can I say? In general, it's I agree with Ankul, but in general, this is a kind of general rule in rheumatology, which this aggressive systemic disease, you need to be aggressive since the beginning. Otherwise, you run the risk of not being able to control the process over the long run. You administer IVIG initially, which is good. It can have an immunomodulatory effect. They are known to work in JDM, also on the underlying disease process. Together with the 3 pulses of methylpres, I guess you have continued with methylpres over time on more conventional dose. The question is, it's as I said, the onset of such a severe, aggressive onset of JDM with severe edema, with capillary leak syndrome, deserves a very aggressive therapy. So you need to be brave enough. What can I say? To face. I know that in your country the risk of infection is probably higher than in my country, but still, I'm not saying that you were not brave, because I know that it's difficult. It's just for the discussion, just to. But the general rule is severe lupus, severe JDM, severe vasculitis, severe systemic JDA with poor prognostic signs. You need to be aggressive since the beginning with corticosteroid and immunosuppression. Anakinra could have helped, as Randy wrote, but I know that you don't have anakinra, so it's so cyclosporin A is also a medication that could have helped. That's it.
Thank you so much. I think we can move on to the next case presentation then.
Yeah, I think we have discussed this part. I just at the last, I would just want to ask Professor Angelo, do you have your own experience of capillary leak syndrome in JDM, and how do these kids?
I should admit that I have never seen capillary leak syndrome in JDM. I've seen in MAS, in some infectious diseases, but outside, of course, this condition, kind of idiopathic forms, but it's very rare, fortunately, it's very rare. No, I've never seen JDM. I've seen cases of edema, prominent edema, particularly of the face, of the periorbital area. In general, I should say that these patients are those who prove more difficult to control. So I can confirm that edema can be a poor prognostic sign, but such a severe capillary leak syndrome I've never seen. I've seen erythromelalgia, diffuse erythromelalgia in JDM, very severe, but the capillary leak never seen.
Fine. Thank you, sir.
MAS, I've seen activation of MAS.
Yeah.
Ferritin, leukopenia.
So thank you, Dr. Ashwani, for presenting this case briefly. It was a really challenging case. May I request Dr. Navodit to present the next case? Dr. Navodit is a junior resident with us. Dr. Navodit, you can share your case.
I think in the interest of time, we'll probably restrict the discussion of the next case to key few points if possible, because we've already overshot the time limit.
Yes. I know it's late.
Yeah, so we will just take the discussion at the end only.
It's not our fault anyway, but it's good because there has been a lot of discussion before, which is very good for us. It was a very interesting, important meeting.
Fine. So probably the storm has to settle down now. So
let's try to be short anyway.
Yeah. So we will take the questions at the end only. So over to you, Navodit, please. Navodit. Yeah.
Good evening, everyone. Is my screen visible and am I audible?
Yes, perfectly fine.
The second case, There was a 7-year-old boy, RK, with systemic juvenile idiopathic arthritis, first diagnosed in March 2018, who presented with a duration of 7 days with complaints of fever, joint pains, chest pain, and a rash on the face and trunk. On examination, the child was afebrile with tachypnea. There was an arthritis of the knee joint. There was an evanescent rash noted on the face and trunk during the febrile episodes. And on cardiovascular examination, there was a pericardial rupture which was auscultated. The possibilities that we kept were a disease flare versus macrophage activation syndrome versus infection, probably of a respiratory focus. The initial investigations, the leukocyte count was 10,600 with predominant neutrophils, and the hemoglobin and platelet count were normal. On echocardiography, there was a minimal pericardial effusion, but normal cardiac function. On chest imaging, there was a consolidation in the left lower lobe on both the chest radiograph and the CT chest. This is the brief pictorial timeline that initially there was fever and arthralgia with need for with tachypnea and need for oxygen support by face mask, which gradually resolved over the course of a couple of days as we started him on antibiotics and stress dose steroids. On initial investigation, the ferritin was 3258 with a cell count of 10,600 total leukocyte count, as we already mentioned. There was clinical resolution of the complaints, but the laboratory parameters showed a rising ferritin, and both the rising ferritin as well as the rising total leukocyte count. So here we had, as we had kept these three possibilities, we had already taken, given cover for the infection with antibiotics. But in view of the persistently increased ferritin, despite giving this initial therapy, we had given a course of IVIG 2 gram per kg for evolving macrophage activation syndrome, because even though the absolute values of the criteria were not met, but the rising ferritin showed a trend in that direction itself. On the in the 18th or 19th day of hospitalization, on the 18th night and 19th morning, the child developed a bout of vomiting, wherein there an episode of vomiting, wherein there were 5 to 6 episodes of massive vomiting, and he went into shock, which required both fluid boluses and inotropic support. And here there was on the investigation, there was established macrophage activation syndrome, and for that, since there was established that they had already given a pulse methylprednisolone followed by oral steroids over a course of 5 days, and even despite that, he developed macrophage activation syndrome, and the ferritin was now on a dangerously steep trend of more than 100,000 or 1 lakh. So we, due to the non-availability of anakinra, we started IV tocilizumab 12 mg per kg and also oral cyclosporin. Now at this time, the cell counts had taken a dip from 29,000 in the second week to now 2,400 with thrombocytopenia associated. And here also, after the tocilizumab cyclosporin, the very next day, the fever and arthralgia resolved, and inotrope support was tapered. The tachypnea and oxygen support, he also required high flow nasal oxygen for a couple of days, and after that, it also was tapered, and the child clinically there was resolution, as well as there was laboratory resolution with dropping ferritin and improving cell counts.
Yeah, just 1 minute, Dr. Navodit, if you could go back. I would like to ask Dr. Ravelli here. So at the point where this child's counts went up, so the ferritin also went up simultaneously to 18,000. Total counts were 29,000. Platelet count was 8.7 lakh. So we know we have now different criteria laid down by your group, and then we had the MS criteria to distinguish between a flare of systemic onset JIA and the onset of macrophage activation syndrome. So going by that, what would your thoughts be at this point in time, whether, although probably the management wouldn't drastically change, what would your thoughts be regarding the diagnosis of?
This is, I understand that the differential diagnosis might consider these three possibilities, but also you should consider that look at ferritin. Ferritin level which raises from already 3000, which is quite uncommon in the acute setting of systemic GA without MAS. It raises to almost 7,000, then 18,000. In such case, irrespective of the other laboratory tests, I would treat this patient as an impending MAS, at least, an impending MAS. And because we know that if you don't control MAS early enough, MAS may reach its full-blown stage. And then this is what occurred, because after a few days, the ferritin raises to more than 100,000, and the platelet count dropped to 40,000. So this was a clear-cut, unequivocal MAS. Then you had to give the pulses of methylprednisolone. So in general, this is a general rule. In severe cases, it might be, let's say, wise to after the pulses to continue for a while with conventional dose steroid, but still maintaining the intravenous route, because sometimes, particularly in JDM, for instance, but in other diseases, can be kind of inflammation and vasculitis may induce kind of malabsorption, gut malabsorption of medication. So it might be, I say, in severe instances, prudent to continue for 5-7 days, 3 days, 5-7 days, conventional dose 2 milligram per kilo, 60 milligram, 80 milligram, whichever dose you prescribe, but given intravenously. And then the question, I guess, might, so you were correct in adding cyclosporin A because of the severity of the case. This is with such high level of ferritin, you need to be, and this drop, profound drop in cell counts, you need to be aggressive as you were. But I think I agree with your choice of tocilizumab because Professor Kron would have certainly said use anakinra, but once more, if you don't have anakinra in your hands, you need to be brave enough, because once more, desperate case, very high risk case, need physician to be brave, but also rational, So the tocilizumab we have seen from the presentation of Randy has a role, definitely has a role in the pathophysiology of MAS. The experience with tocilizumab is very limited. Someone might be worried because there are reports of MAS occurring during tocilizumab therapy, but there are also reports of MAS occurring during anakinra therapy, particularly at lower doses, but also with canakinumab therapy. So it is unclear in this case whether it is the medication or intercurrent infection or an insufficient control of the underlying disease, the causes of MAS. But I think there are reports in the literature, either in both in systemic GA and in adult onset disease, that tocilizumab may help to control MAS. So if you are in a difficulty with the patient, I think I think it was correct to try tocilizumab, which indeed helped very much to solve the situation.
Thank you, sir, for your comments. And in fact, this was the confusing scenario that because we had already given the patient IVIG and IV methylprednisolone for 5 days, and after that the ferritin just steeped to more than 1 lakh, as we have heard in the previous discussions, that such frightening values and accompanied with the clinical deterioration in form of shock, we were left and we chose to give tocilizumab, and then probably the things improved. Yeah,
you might consider reporting this case, publishing this case, because there are only few. I have taken a look at the PubMed before the conference, and there were very few cases, but there are still some positive experience with tocilizumab in MAS. So your contribution may be an interesting addition to the literature.
Sure, so we will take this. Yeah, Navodit, you can proceed further.
Thank you, sir. So as this was a trend of the parameters over the course of the weeks, wherein the absolute values met the 2016 mass criteria only when the frank clinical manifestation accompanied with shock developed. But otherwise, the only ferritin count was meeting the criteria, and the other parameters were, even though inflammatory markers were increased, but the other parameters were not meeting the absolute criteria. So herein, I think there was that the trend showed an evolving mass, as both Dr. Narendra Bagri and Dr. Angelo Ravelli previously mentioned, that that it was an evolving kind of stage. So the absolute criteria may not be met early in the course. On follow-up, he was prescribed oral cyclosporin with prednisolone with biweekly IV tocilizumab. He improved clinically and both laboratory resolution after the tocilizumab. As I think in the previous presentation by Dr. Rakshit Shetty, the children with more than 100,000 ferritin, none of them survived. But thankfully, in this case, I think probably due to the tocilizumab and oral cyclosporin that we started, the child thankfully improved, and he was discharged at day 29 of hospitalization. And at 4 weeks of follow-up, he was doing well. As was already mentioned, that there were conflicting case reports in the literature regarding the use of tocilizumab, wherein in some cases it elicited the macrophage activation syndrome. The exact mechanism that was postulated is not clear, but it is said that there could be selective inhibition of some cytokine pathways, which could enhance the signaling in the other transduction mechanisms. And so the concomitant therapy that which is around the time of starting tocilizumab could also have an effect in this. There have been some positive successful case reports also with this Russian study, the Japanese study, and the Chinese case series of 18 patients, so showing a successful tocilizumab therapy for the macrophage activation syndrome. So the key point of discussion as is discussed, I think already, that could tocilizumab be considered as a therapeutic option for macrophage activation syndrome? I would like again to open this to the honorable experts.
I would add a short sentence, comma, when anakinra is not available. You might add it in brackets, perhaps.
Actually,
because not unexpectedly, most reports come from countries where anakinra IL-1 inhibitors are not available. So clinicians need to do something,
Yeah,
I would like to mention one point, that it was we had written it in the after NAS, that especially in settings where anakinra is not available, but I was just for the pictorial depiction purpose, I removed it just a few minutes back.
Fine. Okay, thank you, Navodit, for an excellent presentation. So I think this was again a case which has summarized one of the key messages of the conference that we have been discussing, that it is the trend of parameters in the clinical parameters trend which defines the mass, not the absolute values. So thank you for this. And any further comments, Dr.
If I can add the last point,
yeah,
consider that criteria for MAS and also for they are classification criteria, not diagnostic criteria. So the diagnosis should be made by the clinician based on his or her skill and experience. Of course, it can be a good reference, the criteria, but do not stick too much to classification criteria, because we know that clinical work is maybe the clinical scenarios may be different. They may require not all syndromes present as it is written in the books and in the publications.
So thank you so much, Dr. Ravelli, Dr. Ankur, Dr. Narendra and team. I think with this, we'll end the case discussion for today. And I would like to call upon Dr. Rakshit Shetty to now just end the session for the day. Thank you.
So we've come to the fag end of third day of cytokine release syndrome conference. It's the first time with a unique meeting with a mixture of both rheumatologists and intensivists. And looking at the participation, I can say that it was a very successful meeting. And the success can be measured not only in terms of the number of participants, but how the engaging participants were, and also what are the learnings for each of us. And I'm sure this meeting met its objectives. The objective was
to explore the world of cytokines in terms of improving outcomes of critically ill. And I'm sure it was eye-opener for many of the intensivists and many of us who are working in this particular country. I think a lot of those talks were highly useful. And I'm sure also for rheumatologists too, I think the perspectives intensives, I'm sure was useful. I would really thank all the experts who joined us across the globe for spending your valuable time. And many of you have been here for all 3 days, especially Dr. Randy Crown, Dr. Scott Scanner, Dr. Pooja Mehta, Dr. Ramanan. I mean, it means a lot to us. I mean, you being here and spending time with us, understanding our concerns, and being very active in the group and answering a lot of our queries, that means a huge. And we all deeply appreciate the kind of effort you put to spend time with us. At the same time, all the delegates who joined over the last 3 days in good numbers across the country. And not just that, I mean, the chat box has been busting with so much of comments, content, discussions, and it's been highly engaging. I think finally I should also congratulate Dr. Chandrika for coming up with such a wonderful program and getting the best of the faculty, because the success of the program depends upon its content and who gives the talks. So, and the amount of effort she's put in connecting to the faculty and making sure the program runs on time and things happen well, a huge amount of applause to her. And with this, I think it was a wonderful 3 days spent, and we thank all of you for your active participation and hope with that we can have similar kind of meetings in the future. Good night and have a wonderful weekend.
Thank you all. Goodbye.
Bye-bye.
Bye-bye. Nice weekend.
Bye.
See you. Ciao Narendra. Bye.
Bye-bye,
Bye.
sir.
Bye-bye. See you soon, hopefully, in person.
Yes.